So highlights of this New England Journal article were that we are potentially experiencing an overdiagnosis epidemic within melanoma. And so overdiagnosis was kind of defined several ways. One was we biopsy too many things, particularly too many benign lesions. Two, we are more likely when a lesion is biopsied, if it has some histologic atypia, to actually call it melanoma, whereas in the past, a similar lesion maybe would have just been called an atypical nevus. Three, we are more likely to have these more what would be called indolent melanoma. So lesions that are melanoma, they're treated as melanoma, but they didn't have the same potential for metastasis as what we would maybe have thought of as melanoma, for example, 50 years ago. So how can GEP help with this? I think what GEP can do is provide objective data. So one, in terms of what we biopsy, we're not just saying this mole has a little bit of an irregular border. We're saying we can actually measure some degree of genetic atypia. Two, in terms of do we call an equivocal lesion melanoma or benign? Again, you can use some genetic information, not just the histologic features. And then three, one of the bad outcomes of overdiagnosis is overtreatment. So by getting genetic information on a lesion's behavior, then we have the potential to actually de-intensify treatment for some patients.